Hello everyone and welcome back to Mastering ECG Workshop, where we challenge your ECG interpretation skills one quiz at a time. Today we have another exciting case lined up. Are you ready? Today's ECG belongs to a 68-year-old man who arrived at the emergency department complaining of severe central crushing chest pain. It has been ongoing for about 2 hours. Do you think you can accurately diagnose this ECG? Let's test your skills using our trusted 7-step ECG interpretation method. For each step, you will have 10 seconds to think it through and write down your answers. Feel free to pause if you need a bit more time. Afterward, we will thoroughly review each step together. Alright, let's dive in. Great job. Now let's see how well you did by breaking it down step by step. Step 1. Heart rate. The heart rate is 100 beats per minute. If you counted 3 big squares between two QRS complexes, you'd get about 100 beats per minute. 300 divided by 3 equals 100. Step 2 is rhythm. Did you spot the P waves? Each QRS complex is preceded by a clear P wave indicating a normal sinus rhythm. The third step is axis. The QRS is positive in lead 1 and negative in AVF, pointing clearly toward left axis deviation. The step 4 is P wave and relationship with QRS complex. Each P wave consistently leads into a QRS complex. The atrioventricular relationship is normal here in this ECG. Step 5 is intervals, starting with PR interval. Did you notice prolonged at about 0.24 seconds? That's around 7 small squares, indicating a first degree heart block. The QT interval. After correcting for heart rate using an online QTC calculator, mdcalc.com, the QTC interval is approximately 439 milliseconds, which is normal. Step 6 is QRS complexes. The QRS complexes are normal, each lasting less than 3 small squares. Step 7, STT changes. This is where the action is. Let's look closely. This is ST segment elevation in leads 2, 3 and AVF. There's about 1 mm elevation in lead 2 and about 2 mm in leads 3 and AVF. These findings strongly suggest an inferior wall myocardial infarction. But wait, there is more. Did you catch the reciprocal ST depression in lead 1 and AVL? These reciprocal changes strongly support our diagnosis. Now, here is a bonus challenge. Did you notice ST segment depressions with upright T waves and prominent R waves in lead V1 to V4? These subtle changes point to an additional posterior wall myocardial infarction. When both inferior and posterior wall changes appear together, it usually suggests blockage of the right coronary artery. Remember Patients can sometimes present with isolated posterior wall myocardial infarction changes on ECG, so stay vigilant. In summary, the correct diagnosis for this ECG is acute inferior and posterior wall myocardial infarction. Clinical pearls and practical tips. Always double check reciprocal changes to strengthen your diagnosis. Be alert to subtle signs of posterior wall MI changes, focusing on leads V1 to V4. Early recognition of myocardial infarctions can significantly impact patient outcomes. Well done, everyone. I hope today's quiz sharpened your ECG interpretation skills. Did you get the diagnosis right? Let me know in the comment. Stay curious, stay sharp, and I will see you next time.